Thank you so much for joining us on this gorgeous Saturday afternoon, at least gorgeous where I am in Northern Virginia. I'm Donna Sorkin, and I'm the Executive Director of the American Cochlear Implant Alliance. We're the organization that's putting on this event today. I've been involved in hearing loss for almost 30 years, actually my whole life, because both my father and his mother were deaf. But of course, in those days, you always called someone hard of hearing. You never said that they were deaf. I have been working full-time in this field for nearly 30 years. I entered the field in 1992 when I became the executive director of one of the nonprofits for adults. And it's been a great experience. I thought I was going to stay for a few years and then go back to what I had been doing before. But of course, that didn't happen. So for those of you that are devoted to cochlear implant access, as we are as an organization concerned about both improving access and improving the outcomes that individuals enjoy with this extraordinary device. And so we are right now finishing up our annual conference, where we had nearly 1,400 people from around the world involved in looking at clinical research and looking at how we can improve the experience for recipients. And that involved clinicians and physicians of various types and educators, scientists, and all meeting together to see how we could improve the experience for individuals like yourselves who are with us today. And it was a bit different than it usually is because, of course, everything's virtual. So this workshop is something that we try to do in normal times, and it's usually done in an in-person setting. And we stage it then because we have all of these clinicians in one place physically, as well as the hotel and the AV, et cetera. And so this year, because we were virtual, we were able to go beyond the normal 2-hour drive time to the workshop and involve people from really all over the country and even from other parts of the world. I believe we have some people with us from Latin America, so we welcome them as well. So what we're going to do today is start out with a discussion of how recent advances have advanced opportunities for children and adults. There'll be time for questions after the presentations. You can type those questions in at any time, and probably they're going to answer them at the end, but go ahead and type those in whenever you wish. So let's get to it. I'm honored to introduce two people that I have worked with over the years who are extraordinary cochlear implant clinicians and scientists. Dr. Megan Nerone from Yale University is an audiologist and director of the ACI program, and Dr. Charles Lim is an otologist and CI surgeon at the University of California in San Francisco. He's also an amazing musician who is devoted to music, and he has even been known to put himself in an MRI machine so that he could see what his brain was doing while he listened to music. No, really, he did that. So over to you, Megan Charles.
Thank you, Donna, so much. We are thrilled to have this opportunity to speak with you today. I'm going to start just by showing you our financial disclosures. And we'll start off with two questions that I'm sure is at the forefront of everybody's mind. Why do children and adults with some usable hearing benefit from cochlear implants? And what benefits can be expected from a cochlear implant? These are questions that I will answer in multiple slides. And I felt like maybe the best way of presenting that information would be to share some of our patients with you. Before I get to that, I want to show you briefly one of the impacts of recent discoveries, and what's changed is really cochlear implant candidacy. So when cochlear implants first became approved by the FDA, in this country, it was only for adults with very profound hearing loss. And as the efficacy of cochlear implants has been shown, that candidacy has really opened up. And this is an area where we've seen a lot of changes recently over the years. So now we can consider cochlear implants for adults and children who have more residual hearing, who maybe have good to normal low frequency hearing and just severe to profound high frequency hearing loss. We can consider them for individuals with something called single-sided deafness, where they have one essentially normal hearing ear and one ear with no usable functional hearing. And we can consider cochlear implants for children now down to the age of 9 months. It's really not something that you need to be concerned about is what are the candidacy qualifications. Your Cochlear Implant Center is well versed in that, but I do want to share with you what a cochlear implant evaluation looks like. So regardless of if you are an adult or a child, we need to get a comprehensive evaluation of your hearing so we really are sure what your hearing loss looks like. In the case of children, they may not be able to tell us, so we might have to supplement that with some objective testing, electrophysiology testing to confirm what their actual hearing is. The bulk of the evaluation is usually done with testing with recorded materials at average conversational levels with appropriately fit hearing aids. So we're really trying to determine what benefit our patients are getting from hearing aids. And if we know that they're likely to get more with a cochlear implant than they get with their hearing aids, that's when a cochlear implant is recommended. It's a little bit more difficult with children. They can't always tell us. So we're looking for a lack of benefit or a lack of progress with appropriately fit hearing aids or a lack of, speech development. And oftentimes we have to include some questionnaires about functionality that might be completed by parents or teachers or speech language pathologists. Regardless, appropriate expectations is listed here for both groups. That's a very key component of cochlear implant candidacy. So with that, I'd like to share with you JS. She was implanted at the age of 71. In 2018, she got a cochlear implant in one ear. And on the left here, I'm just going to orient you to, this is an audiogram. It's just a graph of hearing. And you'll see this on several of my slides, but I'm only going to describe it the one time here. So what you're looking at is pitch on the horizontal axis. So low frequencies is over here on the left and high frequencies here on the right. On the vertical axis is volume, softer sounds towards the top, louder sounds towards the bottom. These X's represent the hearing that she has in her left ear. So you can see she has some good hearing in the low pitches. We would consider this a moderate sloping to profound hearing loss. And then she has no measurable hearing in the high pitches. If you had normal hearing, you would be here in this range between 0 and 20 decibels across here. And average conversation usually takes place around 50 decibels, right around here. So when we fit JS with hearing aids, we saw that we were able to give her access to some sound. Okay. That's what these A's represent. But you can see that even with appropriately fit hearing aids, we weren't able to give her conversational level speech. And the way that hearing aids work, where they pick up sound and amplify it, but they put it back into the ear canal, mean that if there's a lot of damage to the sensory cells of the inner ear, we might be able to give our patients sound, but we often can't give them clarity. We often can't give them a complete picture of the conversation, and that's where they struggle. And that's why many individuals will say, I hear you talking, but I can't understand what you're saying. So cochlear implants work a little bit differently. And you can see how she heard with a cochlear implant here represented by the S's. Because the cochlear implants damaged bypass the damaged part of the ear, they give even access to sound across all of the pitches, right up near the normal hearing range. They don't restore hearing. It is not the same thing as normal hearing, but in terms of access to sound and conversation, it's a huge improvement. So how did JS do? Because the goal of cochlear implants is really to be able to understand speech. I mentioned before that our testing involves listening to recorded materials. We do that for standardization, and we do that so that we can remove any visual cues, because we're really concerned about how somebody is functioning with their hearing aids. In JS's case, you can see her preoperative scores here in the darker blue. She understood 0% of recorded words and sentences in quiet with the hearing aids. After 1 month of having a cochlear implant, she had improved to 46% on words, 67% on sentences, 20% on sentences and noise. And then after 2 years, we continue to see improvement. And that's true for most of our patients. Progress doesn't just stop. We continue to see improvement over the years. So after 2 years, she's understanding over 50% of recorded words, almost 90% on recorded sentences, but we still see her struggling in noise. And that's very common. The patients that I'm going to show you today are not necessarily our star performers. They just represent a range of the outcomes that we typically see. EB is a child who got simultaneous bilateral cochlear implants at the age of 3. EB had a progressive hearing loss, was fit with hearing aids. You can see the hearing loss here, both the left ear, which is represented by the X's, and the right ear, which are represented by the circles, are in the severe hearing loss range. We were not seeing development of spoken language with the hearing aids. Because of that, the preoperative testing really couldn't include a lot of speech understanding measures. Now, with children, we always select age-appropriate lists, so we don't use the same tests with adults as we do with children, but it really is about functionality with hearing aids and progress of spoken language. So EB had no language prior to the cochlear implants. You can see here after 6 months of cochlear implant use on a picture pointing to word task, we saw a huge improvement. And then 2 years post, this child is able to repeat recorded words, phonemes, which are the individual sounds in words, and recorded sentences. And that's what we see most often in children who are implanted early, is that they're able to develop essentially normal spoken language.
Thank you, Meg. It's a pleasure to be with you all today. And I want to just recognize that everyone in the audience kind of has a different perspective, a different level of knowledge. And as you are in different phases of your cochlear implant, either journey or researching, I want to, I think, acknowledge how confusing it can be as you try to digest some of the terminology and some of the trends that are taking place in the cochlear implant world. And a lot of that is a reflection of the history of cochlear implantation and how, as we have gotten a better understanding of how these devices work, how we've learned better techniques, new possibilities have emerged. And one of the things that is kind of a major topic of conversation today among surgeons is this idea of hearing preservation cochlear implant surgery. And so if you've never heard this, you might say, I don't understand what that means. I thought that people that had a cochlear implant don't have hearing. And this raises, I think, the important point that hearing loss is not a binary thing. It's not either you have hearing or you don't. You're not either deaf or normally hearing. Hearing loss can occur across a very wide spectrum. And what is happening with cochlear implants is that primarily in the early days of cochlear implantation several decades ago, you really had to be profoundly impaired in order to qualify to have a cochlear implant. And then over the years, as we saw how well patients were doing with these devices, we started to understand that you could have a lesser degree of hearing loss and still benefit dramatically from a cochlear implant. With those patients, we also started to learn that we were seeing some cases where a patient that had some degree of hearing present in their ear would retain that degree of hearing afterwards. And this wasn't an all the time phenomenon. It was sort of noticed occasionally, intermittently. And we started to question whether or not this is something that we could reliably begin to predict for patients or guarantee for patients. And hence the idea of hearing preservation surgery was born. And so a sort of classic example of hearing preservation surgery is the audiogram that you see here, where somebody's has a good amount of hearing in the low frequencies, but a pretty poor amount of hearing in the high frequencies. And the net result of all of that is that they are struggling. They may not feel that they are deaf, but they feel like life is very difficult. And I would urge you, from a candidacy consideration perspective, there's a lot of numbers and a lot of criteria that are formalized, but the truth of the matter is, if you are struggling with hearing and with all of the solutions that you have tried, it may be time to consider a cochlear implant if you've never considered it. Now, with this patient, the obvious concern is that if we were to put a cochlear implant in, that we might lose all of this residual hearing that is present, especially in the low frequencies. And low frequencies are crucial for things like pitch and for voice and to pick up the fundamental frequencies of sound. And so in the literature, if it depends now, it's almost become a point of pride for surgeons to be able to say that they can offer hearing preservation techniques, but depending on which electrode you're using, how the ear was to begin with, how the CT scan and anatomy looked, different studies are quoting anywhere from 20 to 80% rates of hearing preservation. And I would say that it's fair to say that approximately half of the times we're able to preserve some degree of hearing. Now, how you define hearing preservation may vary in the studies, and so that's an important thing to take into account. And I want to show you a video of how we try to accomplish this. Now, this is going to be a surgical video, and so for those of you that don't like the sight of anything red, I'll try to keep this very simple. But basically, I'm going to show a cochlea being opened, and you're going to see a tiny hole being made. And so if we could just advance the next slide. What we're looking at here is a video of the cochlea, and that's a little membrane called the round window membrane being opened, and that's going to lead to a tiny opening, a little black dot there. And through that black dot, we're actually accessing the basal turn of the cochlea. It's sort of the entrance to the snail shape of and this view that you have is a view through the mastoid bone, which has been surgically opened to allow us to get to the cochlea. And then what we're going to do, if you could go to the next slide, we're going to take an electrode. So here's the opening. And we're going to take this very small cochlear implant electrode, and we're going to try to thread it next video. We're going to remove a little bit of the fluid from the inner ear here, just to help decompress it. And this electrode is going to be entering that opening that we made. And you can see it just about to enter that opening that we made. It's going to take a little bend right here, and then it's going to go inside. Now, as slowly as we can, we're going to, in very controlled fashion, atraumatically try to insert this implant. And it's almost imperceptible, the rate of insertion, because I'm trying to control this very, very slowly. But if you sort of stare at those metal electrodes going in, you can eventually see them disappear into the inner ear. And this process goes on for a couple of minutes until the device is fully inserted. And so why don't we go on to the next slide? Now, in this particular patient, this was where they were at day 8. So a week after surgery, this is their hearing test. And that it was the left ear that was implanted, so the blue line here. And then if you could advance the slide again, and we can just compare it to this preoperative audiogram. So you can see how they now have a little bit of a conductive hearing loss. That's usually from fluid or blood that's behind the eardrum. But the low frequency contour they had in the left ear is essentially preserved. It's not perfectly preserved. There are some small changes if you kind of go frequency by frequency, but by and large, the subjective experience of that patient with respect to their low frequency hearing is the same as it was prior to surgery. Perhaps most importantly, if we could go to the next slide, is that this patient doesn't even particularly care about their residual low frequency hearing. What they're most impressed by is their electrical hearing, because they're finding that with the implant, they're hearing far better than they ever did. And they're actually not even paying much attention to the fact that they have some low frequency hearing. And so one of the things that we're finding is that even in patients who have low frequency hearing, that not all of them are choosing to use bimodal amplification together with implant strategies, or the perceived benefit that they're getting from the acoustic portion of their hearing may not be as great as we think. And that's probably because of the relative ratio of acoustic to electric hearing that's present, and also what's going on in the other ear. From a surgical perspective, we would always hope to preserve as much hearing as we can. And now hopefully you can understand how that's possible. Thanks.
Thank you, Charles. So to piggyback on what Dr. Lim was saying, I thought I would share with you one of our patients who did have hearing preservation. The exciting thing from a clinical standpoint of this technology and these new techniques for preserving hearing is that, as Dr. Lim said, while some patients may not notice a benefit or prefer to listen with acoustic amplification in that low frequency area, some do. And you'll hear this referred to in a few different ways. So you might hear it referred to as hybrid hearing or EAS, but essentially we're talking about the ability to send both electrical stimulation through the cochlear implant electrode and acoustic amplification through the ear canal. And we can do this within the same ear for our patients who have hearing preserved. So this is AB. She was implanted at the age of 41, and this was her hearing preoperatively. So again, all of our patients have left ear cochlear implants. I assure you that's not the case, but it just seems that the three that we've shown you so far do. So AB has good hearing in her left ear for the low pitches. Again, she drops off to the profound hearing loss range for the high pitches. This is how she did with hearing aids. And so with or without hearing aids, she had really good access to low frequency information. But even though the hearing aids gave her the awareness of conversational speech, she was struggling to understand. Okay. After the surgery and 2 years post, this is the hearing that we were able to preserve for her. And this means that she absolutely has enough hearing that we can stimulate it acoustically. So this is how she performs. The blue bars are pre-operatively, and you can see post-operatively she has jumped up to over 90% on recorded words, 99% on recorded sentences, and in AB's case, she also seems to perform very well in noise, and that's at the 2-year mark. So one of the most exciting things that's changed over the years with the recent scientific advances is the external technology. And the nice thing about this is that our patients can take advantage of these improvements without requiring another surgery. So what have we seen changing? The processors are getting smaller and smaller. There are different wearing configurations where now we have options to not require that anything is worn behind the ear. The battery technology is improving. Usually we can offer options for disposable or rechargeable battery technology. All of the companies offer waterproof options. The control of how you adjust the sound for the implants has changed dramatically. And now we have remote control options and apps that can be downloaded onto cell phones that turn your phone into a remote control. So you can change programs and change volume and change listening settings. And that leads me to connectivity, which is probably the single most notable advancement in recent years for the external technology of cochlear implants. Now we can connect these devices to cell phones. Most, if not all, of the processors have access to telecoil, which is a little coil that's built in that picks up electromagnetic energy instead of sound. And so that allows our patients to connect to rooms that are looped with an induction loop or use FM or infrared sound stimulation delivery. We have different listening devices. I'm going to show you some of these in the next slides, but we can connect them to remote microphones or gadgets that connect to the television, so we can stream sound from almost anything wirelessly directly into the cochlear implants. And likewise, Bluetooth technology and Bluetooth LE and 2.4 gigahertz, which are all just different ways of transmitting sound wirelessly into the processors, is available. Roger is is an adaptive microphone technology where the volume of the microphone changes itself to optimize the signal. So with that, the cochlear implant processors now also work very well with hearing aids. So if we have a patient who is a candidate for a cochlear implant in one ear, but not in the other, we can fit them with a hearing aid. And now we have a lot of options for making the cochlear implant and the hearing aid work together or connect to some of these accessories and telephones so that they really work synchronously together. And then, as we mentioned already, we can combine electrical and acoustic stimulation within the same ear for the patients that have hearing preserved. So I just thought I would show you, what does this mean for our patients? This is RT. This is a child who had progressive hearing loss, received a cochlear implant at the age of 5 in October 2011. And 3 years later, with the original processor, this child understood 58% on recorded words and 78% on those phonemes, the sounds in the words. Just by upgrading to a new processor in 2017, we saw a huge bump in performance, a huge improvement, both in the words and the sounds of the words. And then again, with a second upgrade in 2020, we saw additional improvement. So as I mentioned, backwards compatibility means that as new technology comes out for the external sound processors, we can offer that to our patients. They can take advantage of hearing better, connecting better to phones and different electric devices in their world without requiring another surgery. In RT's case, we also know that the new technology increased her wear time. So the new processors now have something called data logging, where they can tell us how often they're being worn, what program is being used, what volume setting is being used. And so we know that with the new technology, this child was also wearing her device more consistently. And according to the parents, one of the reasons was the connectivity. So the ability of the processor to connect to a phone and connect to a microphone made it that much easier for the child to wear. So how do cochlear implants work with hearing aids and other technologies? Some of the companies have partnered with a specific hearing aid manufacturer to develop devices that really communicate with one another. Other technologies have partnerships that allow the implants and the hearing aids to function independently, but receive signals from phones or other devices at the same time. So I thought I would share with you one of our patients, BM. She was implanted at the age of 56 with a left cochlear implant in 2019, and then we subsequently fit a right hearing aid for her. This was her hearing preoperatively. The X's represent her left ear, the circles represent her right ear. So again, good low frequency hearing and very significant high frequency hearing loss. And this is how she did. Now, she had stopped perceiving benefit from the left hearing aid, but was still getting a lot of very usable information from the right hearing aid. And you can see that here, the right hearing aid responses represented by the A's. So the hearing aid was really giving her good low frequency information. And then after the cochlear implant in her left ear, she was able to have full access to the sound spectrum through the CI. In terms of her performance, you can see here with the left hearing aid represented by these first 3 sections, preoperatively, she was really struggling. And then after 2 months, we saw significant improvement on recorded words and sentences. And likewise, after 2 years, a significant improvement. Somebody might ask, why did she change from 80% at 2 months to 72% at 2 years? This is not something we would consider to be clinically significant. We would consider that to be stable. But as far as working with the hearing aid, which is represented here in the right, you can see when she's wearing the cochlear implant and the hearing aid, this is sentences in quiet, she is seeing a huge improvement to the point now where she's understanding 98% of recorded sentences in quiet. And in noise, she's over 60% here. So the nice thing is that the cochlear implant processors and the hearing aids typically have telecoil built in. And so that allows our patients to connect to all sorts of devices or make use of the sound systems if they go to a room that's looped, like an auditorium or performance theater. Telecoil is used very commonly in Europe. It's not as common in this country, but it is very much available. And so we are able to use that technology a lot in our bimodal patients. Each of the companies has come up with slightly different alternatives for their connectivity options, but you'll perceive a similar theme through all of them. So with Cochlear Americas, I'm showing you here on the left, this is a Nucleus 7 sound processor. And if you see this little wire coming out here, this is configured for electroacoustic or hybrid stimulation. So when we're programming this device based on our patient's hearing, we can tell the processor which frequencies we want to send acoustically. This would release the sound into the ear canal, and which frequencies we want to send electrically, where we're sending the transmission through a coil and stimulating electrically through the implant. Okay. Cochlear Americas also offers an off-the-ear option. This is a Canso 2 processor. With either one of these, they connect to iPhones and some Android phones. So you can stream music, phone calls, videos from a cell phone directly into the processor. This is the app that is available for download on the phone. And these are some of the accessories that can be connected. So these are remote microphone technology. I tell my patients that this is my favorite device. The transmitting range on this is over 80 feet. And it can also be connected to anything that has a headphone jack. The TV streamer gets plugged into a television. Both of these devices stream the sound from whatever they pick up or whatever they're connected to wirelessly to the processors. A phone clip is available to allow Bluetooth connectivity if a cell phone is not directly compatible with the processors. So like I mentioned, the connectivity piece is really significantly changing and improving very recently for our patients. Similarly, Advanced Bionics offers really all of the same connectivity options. So we have wireless streaming available. We have Roger microphone technology available. Again, that's an adaptive microphone where it adjusts its own volume based on the noise in the background. Classic Bluetooth is available, where you can wirelessly connect to the processors, and they have other devices as well, TV connectors, remote microphones. In Advanced Bionics' case, they have special technology using 2.4 gigahertz wireless that allows two processors or a processor and a hearing aid to communicate with each other. So those devices work together to make adjustments and optimize the hearing based on a changing environment. With Medell Corporation here, you can see their Sonnet 2 processor, and you can see how we would configure it for that electroacoustic stimulation where we attach an ear mold. Again, we're sending some information acoustically, some information electrically. We also have a Rondo 3 processor, which is an off-the-ear option. And just like with the other companies, we are able to connect wirelessly to phones using Bluetooth. This is a neck loop, so this is a really good option for a bimodal user who has a Medell implant, because this loop can communicate through Bluetooth to a phone, and then through the telecoil of a hearing aid and a processor together. This is a device that's a 4-in-1, so this can function as a microphone and a TV streamer and a remote control, and a Bluetooth link to a telephone. And then also, likewise, a handheld remote control or an app that can be downloaded. So really all of the companies offer amazing connectivity options to allow our patients to really take advantage of what's out there in the world, and however they want to listen for phones or televisions or anything, there are options for making their external technology work seamlessly.
Now, one of the things that Donna alluded to was my interest in music, and it is true. For me, one of the things that I love most about being alive is the ability to hear music, and it's actually one of my main inspirations, not only to be an otologist, but to try to improve the sound quality of a cochlear implant. You can see that most of the sort of metrics and things that we've discussed are very much speech-based. And if you look at the history of cochlear implants, it was simply the case that they were originally designed to hopefully provide speech. There was never really an ambition that they could provide music, just given the complexity of music. And so what's happened is, as we've gotten better with speech processing with cochlear implants, we started to ask about more difficult signals. And the first signal that was, in a way, an obvious target was music. And so many of you are probably musicians or love music or have musicians in your family, and it plays a big role in our social life and also what makes us happy. And I have to give you, I think, a balanced, measured view of where we are with cochlear implants and music. It is still the case today that despite success with spoken language, most cochlear implant users just don't hear music well. Now, that doesn't mean that they can't hear it. It means that they don't hear it well from the perspective of a musician. And so if we go to the next slide, this graph here shows us a little bit about, if we could, great. This graph shows us a little bit about how we can start to view the acoustics of speech versus music. And if you look at the orange center core, that's kind of the dynamic and frequency range that's occupied by language, whereas music in the sort of reddish color is much larger than that. So what you're seeing is that the acoustic boundaries of music, because almost any sound can be employed in a musical context, are much broader, both in terms of dynamic range, but also frequency range. Furthermore, the kind of purpose of listening to music is very different than the purpose of listening to speech. For music, if it doesn't sound good to you, it almost defeats the whole purpose of it. Whereas in speech, you probably primarily want to make sure that you understood the words correctly. You can understand that when we're doing sentence and noise testing, we're not asking how pretty did the voice sound to you. We're asking if you heard the sentence. But in music, it has to sound right, or else it no longer is music. And if you go to the next slide, this is a kind of breakdown of musical elements. And this is sort of a summary of a lot of research that's taken place over the years by many different groups. But if you kind of look at the big building blocks of music, you can break them down into pitch, rhythm, timbre, sound quality, and dynamics. And these are kind of large tasks that a cochlear implant must be able to process successfully in order for music to be heard properly. And you'll notice that the ones in green are the ones that are kind of done well. And there's only two, and they're all based on rhythm. And so it turns out that cochlear implants are very good at conveying basic timing information. And that's because the temporal sort of synchronicity of the device is intact. And so if you hear a rhythmic pattern in music, you will hear it through the implant. Now, that's not the same as saying that musical rhythms, when mixed with pitches and other timbres, have the same integrity, because that's actually a much harder thing to test. If you look at the things that are in red, these are all the things that we need to improve. And you can see right away that it's a large number of things that are not working that well in music. So pitch being the biggest one, I would say that if we could target one thing about music that we would want to improve, it would be pitch, because unfortunately, cochlear implants today are essentially out of tune but not only are they out of tune, you just don't have the number of pitches available to you through a cochlear implant that you do in music. And so you don't have enough pitch information, and the pitch information that you do have is not necessarily accurate. And all of these things combine together to ultimately convey an emotion. And so it can be fairly, I think, well understood that most of the reason why we listen to music is to feel something. We want to convey, we want to receive that musical emotion. And it is those building blocks of music that's giving you the ability to hear those emotions. Now, when you change or distort a sound parameter in music, it's not that you no longer are hearing something, and that something can be musical, it can be interesting, but it may no longer be accurate. And the emotional information that you're getting from it may no longer be identical to what was intended by the composer or by the recording, et cetera, et cetera. And so if you go to the next slide here, the geometric kind of linear organization that you expect to hear when you play if you could just go up and down a piano keyboard and go to the next slide, we have to contend with the fact that the reality is that it's a little bit more something like this. The piano keyboard is not in the best of shape. Some keys are broken, some keys are missing. There's also potentially some keys that are extra wide, meaning that you keep playing the next key, but it sounds the same. And then there's even some keys where the keyboard seems like it's been flipped backwards, where the higher up you're going in pitch, it sounds like it's going slightly lower in pitch. And so there can be reversals. Now, all of this is to suggest that music is, in a way, the pinnacle of hearing. It's the hardest thing there is for us to hear. And so I view it not as a sign of despair, but as something to aspire towards. It's the Mount Everest of hearing. And so if you could hear music well, you could hear anything well. And likewise, far from viewing music as entertainment, I view it as something that represents the most challenging, complex, and elaborate form of sound. And so if we wanted to try to design the perfect cochlear implant, we need to try to target it towards being able to handle the needs of music. So then you could perceive the rest of the auditory world perfectly. And we have seen time and again, there are inspiring stories of patients, musicians, music lovers, that using their technology, they're outperforming what we would have anticipated. There are people that are able to perform on a professional or semi-professional level. There are music conservatory students, prelingually deafened children that were implanted late that are playing piano. There are CI composers that are writing music for CI listeners. There's concerts specifically for CI users. And there's a range of training apps out there and ways to employ music to understand hearing better. And I think what we're finding is that our assumptions of what music should be tempered, because in the end, what matters most is how much that musical experience is impacting that user's life. And I think if you can maybe recalibrate what you think music should sound like and instead flip it around to understand what you are able to hear with the implant, particularly if you have some low frequency hearing present either in the same or the opposite ear, the musical experience can be quite compelling. And there's nothing quite so remarkable as seeing a group of cochlear implanted musicians play together. It's just a striking, heartwarming thing to see. And it's a testament to where we've come, but also I think an indication of how much further we have to go. Thanks.
Thanks, Dr. Lim. Feel free to jump in here on this slide with me, but I alluded to in the very beginning how having appropriate expectations is really part of identifying good candidates. So this is what we tend to talk about with our patients preoperatively. We want to prepare them for what to expect. So we tell them the cochlear implant will not sound like normal hearing. When we first turn it on, we hear all sorts of descriptions. I've been told I sound like a robot or like a cartoon character, Mickey Mouse, Donald Duck, chipmunks, Munchkin from The Wizard of Oz. And what I tell my patients is the first day we turn on your cochlear implant is probably the worst it will ever sound. It will only get better with time and during the adaptation process. So what we know is that it becomes more natural over time. And there's some really exciting research coming out now from Mike Dorman and some other researchers who are looking at the single-sided deafness population and asking these recipients who have one normal hearing ear to describe what they're hearing from the cochlear implant in their other ear. And because they have a within subject comparison, it's really exciting to hear how they shape the signal of what they're hearing. So he gives them access to, filters, and they can make the sound warmer or more tinny or more bassy. And the reality is that once they've adapted to the signal from the cochlear implant, it's quite close to normal hearing. It's not the same as normal hearing, but their depiction of the sound quality, we're not too far off. It's very understandable, and it only gets better over time. So we talk to our patients about the adaptation process, and no matter what it sounds like in the beginning, after about 6 to 12 months, they should be reaching a good amount of speech understanding. Of course, we can't guarantee outcomes. And as we've talked about, there is always a risk of losing or having a change in their residual hearing. We tell our patients that they're likely to still struggle in noisy situations or competing listening situations. But unlike in the beginning of cochlear implants, where we were counseling our patients that they probably wouldn't be able to use the telephone, or they probably wouldn't be able to listen to music, we're having different conversations now. So we tell our patients they're likely to be able to use the telephone. And now there are all sorts of apps and caption options for those individuals that are still struggling on the telephone. As you shared about music, we had that conversation of the technology still has a way to go, but there is a lot of enjoyment to be had with music, especially if we can give them access to some of the low frequency information in that same implanted ear or through the hearing aid on the other side. And then we tell our patients that some amount of rehabilitation might be needed to reach optimal outcomes. So that might be self-directed listening at home, where they're, listening to podcasts or reading along with an article, reading an article and listening out loud to the words. Or for our parents, we talk about providing an auditory enriching environment. The 30 Million Words initiative is really about making sure that they're submerged in language. And then in some cases, we have to include an auditory verbal therapist or a listening and spoken language specialist to help our patients really achieve those outcomes. Did you want to share anything else that you typically talk to your patients about?
I think that's great, Meg.
Okay. One thing that can be very frustrating for me as an audiologist is when my patients come in with those misconceptions, or they have these obstacles to proceeding with the technology. And very commonly, there's a fear of losing what they have. These are patients oftentimes who have used hearing aids for a very long time, and they hold on to what they're getting from those hearing aids. And there's a fear, it's almost a leap of faith that they have to take before they make that decision to move forward with a cochlear implant. But like I said, it is our job at the Cochlear Implant Centers to only recommend implants for those individuals where we believe that the outcome with a cochlear implant is going to be a far greater benefit than anything that they're getting with their hearing aids. And we're very careful that we don't want to recommend this procedure for somebody that's likely to get the same outcomes from traditional hearing aids. I'm sure many people saw The Sound of Metal or have heard about it. It's a movie that came out recently. It won a couple of Oscars. And this movie did a great job of portraying the emotional grief that somebody might experience when they have a sudden hearing loss. But unfortunately, this was very well received in the public domain, and there were some key misconceptions in the movie. So when the lead character was told that insurance doesn't cover cochlear implants, that's not the case. Cochlear implants are covered by most private insurances and Medicare and Medicaid. So, for those individuals that are concerned about the financial costs of a cochlear implant, this movie didn't help us very much. Likewise, any individuals who have a fear of surgery or what the incision will look like. And Charles, maybe you can speak to this, but in the movie, they had these huge S-shaped incisions back to probably what the procedure was in the 1980s. And now, minimally invasive surgeries with almost imperceptible incisions behind the ear is what's used. So this movie didn't portray what the current cochlear implant procedure would look like. A lot of our patients are concerned that something new will come out, and I'm going to address that in the next slides. They're concerned about it being brain surgery. It's not brain surgery. Dr. Lim, you can speak to that a little bit more perhaps. And we do have to agree that music won't sound the same. But as you shared, there still could be a lot of enjoyment coming from music.
Yeah, thanks, Meg. And then I would say that music already doesn't sound the same for people that have this degree of hearing loss. I mean, we're not talking about perfect hearing to begin with. And so I think the question is whether or not the hearing you get with the device is better for you. And in almost every case, the answer will be yes. Now, I do want to make a comment about surgery. We've advanced a long way. Yes, it is still surgery, but we're talking about a procedure that surgically typically takes 90 minutes to 2 hours on an outpatient basis. It's a really efficient thing. And it's from a technical perspective, while it's sophisticated surgery, most otologists, neurotologists consider this sort of a bread and butter type of procedure. This is one of the most common surgeries that I do. And usually if you have a preoperative CAT scan, you can predict almost exactly what's going to happen during surgery. And so it's one of those things that we're, I think, quite comfortable with. I think the idea that it's brain surgery is, yes, it's the ear is near the brain, the inner ear is near the brain. If there are some unusual complications, you could somehow get towards the brain, but that would be a highly, highly, highly unusual thing. And what we're really doing is providing electricity to the inner ear structures so that the auditory nerve will provide sound to the brain. And I want to just tell you that most patients that have this surgery are surprised pleasantly by, I think, how easy it was for them to get through it. I think that they tend to view it as the real big hurdle, but everything that comes after the surgery, that the discipline and the effort that you need in the first year or so trying to learn how to hear again, that's to me, the surgery is just the beginning, and it's a very fast, I think, relatively benign experience for most patients.
Thank you. So I'm sure we both get this question very frequently. Should I wait to receive a cochlear implant until I receive less benefit from hearing aids? And there is a lot of research going on that our patients come in asking us about, and they want to know, should I wait? Hair cell regeneration has been discussed for probably as long as I've been an audiologist, if not longer. And now there are other research going on in terms of optogenetics and infrared cochlear stimulations. So I wanted to spend a minute to just talk about these. Hair cell regeneration shows a lot of promise. The research is ongoing, and there's an international project going on where many researchers are grouping together to kind of look at this, and it is showing promise, but it's nowhere close to being available on a human basis with consistent outcomes. Using those gene therapies, light stimulation, to modify the nerve fibers and have them make them sensitive to light. That shows promise in improving the specificity of cochlear implants. And infrared cochlear stimulation shows some promise, but unfortunately, even in the annual model, the research isn't showing a great response after the animals have lost their hearing. And there's always new cochlear implant technology being worked on as well. So is it better to wait? So before I answer that question from my perspective, I thought I would talk for a moment about what are the effects of untreated hearing loss. And Dr. Franklin has done some really compelling research linking untreated hearing loss to cognitive decline. This is a quote that he has on his website where it says, "The greatest impact of hearing loss might not occur in our ears, rather what takes place between them." And what that means is that if we don't treat hearing loss, we see difficulty communicating, but we also see poor quality of life, loneliness, depression, social isolation. And for adults, we see cognitive decline or risk of dementia. In 2017, the Lancet Commission on Dementia Prevention listed hearing loss as the single most modifiable factor for reducing the risk of dementia. So what I talk to my patients about is, we don't really have the luxury of waiting because some of the changes that take place are almost irreversible. Also, neurocognitive changes. So what's happening in the brain? Anu Sharma is one researcher who's worked extensively here, but many others have as well. And what we know is that time is sensitive for our patients, and there are critical periods here. So for children, earlier is better. There's a reason why now we're implanting children as young as 9 months. We know that for developing language, the earlier the better. And ideally, we need to give them access to sound before the age of 3.5 years. But what Anu's research has shown is that after about age 7, we cannot achieve the same outcomes. Also, there's research coming out that's suggesting that if we don't have hearing loss treated, that the auditory centers of the brain are going to be taken over by other functions, and it's called cross-modal reorganization. So what this image is showing you is that the auditory cortex is being taken over by visual and somatosensory functions in an individual with not very significant hearing loss. And then the really exciting research now is that there's evidence of being able to reverse this if we treat the hearing loss. So what this all adds up to for me and what I share with my patients is that we don't really have the luxury of time. And the way that this research is being done, it's better to give our brains access to the sound now, because in all likelihood, keeping the brain functioning in terms of using auditory information is going to be necessary in order to take advantage of any of the research developments that come in the future.
And I think the question of when to actually make the decision to go ahead with a cochlear implant has to be taken in the context of the fact that today there still is, unfortunately, no FDA-approved drug treatments for hearing loss. I mean, we don't have any medical therapies that work for hearing loss. Now, hopefully this will change. And one of the things I'm most excited about is that there are a number of companies that are trying to improve these things. And like the way the field of cochlear implantation has evolved, it's very likely that the field of molecular and other therapeutics will evolve on their own pace. Hopefully these two fields will work together and merge so that we can take advantage of what we've accomplished in both. In the same way that it's hard to know when to buy a computer or a smartphone or a car because there's always innovations and improvements in technology, the same thing is true for CIs. There's always external improvements, there's always internal improvements. But right now we're in kind of a golden age because we have MRI compatible magnets, we've got a wide array of electrode types, We have softer atraumatic electrodes. We have electrodes that can go against the nerve, against the lateral wall, and in the middle. And we also have a fourth company, Oticon Medical, that's currently undergoing FDA approval process for CIs in the United States, which leads to more choices for patients. And hopefully in the future, via a cochlear implant, a way to deliver any of these drugs that will eventually come in. And so I would say that there's been a lot of change and a lot of exciting things. And hopefully with that, we can head on to our Q&A.
Yeah, thank you, Charles and Megan. This was really very interesting to hear, and I hope it was helpful for listeners. And I think there's a lot of patients on here, so thank you again for this very comprehensive summary. I think we can maybe tackle some of those questions that were put into the chat here. I think that many of them are for Megan, actually. Many of them are somewhat audiological questions, but maybe Charles, you can chime in as well, right? So first question we had was, how is adaptation affected when a second implant is placed a couple of years following the first implant?
It's a really good question, Oliver. I think that it depends. Everything is on a very individual basis, and the answer for adults might be different than the answer for children. But typically, if we're not dealing with a long period of auditory deprivation, we see a second ear catching up a little bit more quickly than maybe the adaptation process for the first ear. So whereas, an adult who gets a cochlear implant in one ear, it might take them, 3 to 6 months before they really have consistent speech understanding. If we put an implant in the second ear a few years later, and they've been using a hearing aid in that ear and maybe have continued to have progressive hearing loss, we often see a faster rate of adaptation and achieving those same kinds of outcomes. In children, again, the earlier the better. So I would say the same thing if it's at a young age. But we've had a lot of patients who were implanted in their first ear, maybe at the age of 3 or 2, and then it's not until age 11 or 14 where they get the second implant, and their adaptation process is highly variable and often dependent on whether or not they've continued to use a hearing aid in that other ear. But what we know is that auditory deprivation definitely can slow progression of outcomes or progress in general. So it's really important to keep stimulation going to an ear as opposed to just getting a device in one ear and not doing anything with the hearing on the other side, because if that ear is not stimulated in any way for a long period of time, it does negatively impact outcomes.
Those are some great points, Megan. I would argue too that there's several papers in studies that demonstrate the negative effects of waiting too long for that second year, especially in the pediatric population. Any thoughts, Charles, on this? Any additional thoughts from your?
Well, I think it's important to know that even though there's right and left lateralized hearing mechanisms in the brain, there's also plenty of bilateral processing that takes place. So when you do have one ear that's stimulated, a lot of the central auditory structures are being processed that would handle the other ear as well. And so you're fortifying or building up these networks in your brain. And I think that will help the adaptation process for a second ear when that happens. That might be responsible for why the second ear tends to catch up a little more quickly.
Okay, that's a great point. So certainly I get that question a lot from not just adults, but also from families of children who are recipients that, they do well with one side, and then, the second ear, they stop wearing the hearing aid. Basically means, to me, that's sort of oftentimes when we would push the trigger on the second implant. But some families and patients want to hold out because of new technologies. Would you think in that scenario that it's worth holding out?
It's there's never a clear time the clear answer of when one should move ahead with technologies. Sometimes you're in an awkward state in a product cycle where you know something is going to happen. Let's say you've been using a particular manufacturer's device and you know that they're about to put out a new processor internally, and you might want to wait a few months. But I would never think that that kind of decision should dictate years of waiting.
Megan, any thoughts on your end?
No, I would agree completely with Charles. And as I said initially, I think this has to be taken on a very individual basis. What we know about lengths of auditory deprivation and how that can negatively impact outcomes needs to be considered.
Yeah. It's important to remind ourselves, the duration of deafness is the most predominant predictor of cochlear implant outcomes, at least in adults. Only accounts for about 20% of the post-operative variance that we see, right? The actual performance with a cochlear implant. So we always argue that, hey, it's such a strong, predictor, but even though it's the strongest, it's still not very good, So some of the other questions we got are predominantly for Charles, and it seems like there are several musicians in the chat here. And we had one here as a former musician, professional musician, I should say. And since my CI was activated 3 weeks ago, so congratulations on going forward with that, number one. 3 weeks is not a long time, but I have been testing my pitch perception by playing scales on an electric keyboard. When I go down to a low F and below, I suddenly get a huge buzz. What causes that, and is it temporary? Can you recommend an app for improving pitch perception? So some kind of self-training. Maybe Megan, you can start with that and this, and maybe Charles, we have you add to what Megan has to say.
I'll do my best. I am not a musician, so I think Charles might have a better answer because I don't really know what that low F correlates to in terms of frequency. But what I would say is that 3 weeks out is a very short amount of time. And you are likely very early on in the programming process of going back to your audiologist for adjustments. So, in the beginning, we oftentimes cannot optimize the settings for our patients. We might have to give them a reduced range of electrical stimulation until they build up kind of a tolerance to it. So what you're hearing through the implant right now probably is not what you ultimately will hear a year from now, just because of the way that the devices are programmed. And that's why, we have our patients come back regularly so that you do often go back to the audiologist 5 or 6 times over the course of that first year for the programming adjustments.
Great points. Charles?
And I think if you're a professional musician, you can appreciate a couple of details here. First of all, a cochlear implant does not provide good apical stimulation of the cochlea generally, which means that you're going to often have difficulty with low notes. And so if you look at the fundamental frequency of the bottom half of a piano keyboard, a lot of those fundamental frequencies are actually out of range compared to a CI prop. So what you're probably having is robust stimulation of your most apical electrode, meaning the one that's furthest in, but it's not, it may be too much stimulation for that part of the ear, which is why it sounds buzzy. And in the meantime, you're not necessarily getting clear pitch percepts. Probably what would need to happen is, as far as training goes, is that you would need to do a combination of things like looking at the musical spectrum of the note using a spectral analyzer. I tend to use Logic Pro to do my spectral analysis, but any audio editor can do this. And then actually sitting at a piano keyboard or an electric keyboard and changing the timbre to the simplest kind that you can, almost like a pure tone, like a flute, would be the best way to test individual pitches, because piano notes themselves have so many complex harmonics that it's going to activate a more complex spectrum on your electrode map. And so keep working at it. It does take a very, very long time, but with dedication, you can make significant improvements.
Yeah, it seems 3 weeks is very, very fresh, obviously, so yeah, we hope you can make these improvements here soon. Next question is sort of a long one, and it relates to the sound processor, new advanced bionic sound processor, the M90. And this person recently upgraded and music perception has improved exponentially in every area that you marked as red on your slide. This person majored in music, and just now 9 years after receiving the cochlear implants can enjoy music. Before I could enjoy listening to music, streaming and listening live to a variety of musical ensembles. But just to change a processor with no mapping changes has been a game changer. Yeah, Charles, any thoughts?
Yeah, no, congratulations. I'm really glad to hear that. The Marvel is new, and it's so new that I haven't done any real research with it. I will say that I've been a research consultant and collaborator with Advanced Bionics for many, many years now, for really decades. And so I'm glad to hear of that success. I've always enjoyed the way that Advanced Bionics engineers are approaching musical questions. And I think that hopefully some of their approach has made their way into the technology. But I do look forward to future research on patients that are using the Marvel.
Yeah, really remarkable that no mapping changes have really led to this kind of improvement. So again, congratulations. We're certainly thrilled to hear that. The next one's probably one for Megan, so I'll read this out loud. Will the next release of Cochlear's processor include a built-in telecoil? As a cochlear implantee for over 20 years, I use T-coil a lot, and my most efficient / preferred method for T-coil is built in, not just accessible via an app or a mini mic. I don't want to have to carry an accessory, so please continue to include built-in T-coils. I guess this is probably one for the manufacturers more than for us. Maybe any thoughts on the kind of trend that you see in clinic of what patients prefer to use, maybe what children prefer to use as opposed to adults, et cetera? Maybe you can chime in here.
Sure. So I don't see any pattern of cochlear implant manufacturers really moving away from including telecoils in their processors, with the exception of the off-the-ear styles. Because those devices have all of the components in a closer proximity to one another, I know that there can be some issues having the electromagnetic coil with some of the other electrical components. So, for example, in Cochlear America's most recent off-the-ear processor, I believe that they were not able to put a telecoil in there. However, if that's something that's important to you, you can certainly continue to use their behind-the-ear processor, which does have a built-in telecoil. What I would encourage my patients to do is to experiment with the different types of technologies and the different connectivity options, because we never really know what is going to work the best. And you really have to try them. So over the years, the orientation of the telecoil has changed in the processors. Sometimes if it's, in one direction, it might be better for telephones. Other times it might be better for a neck loop. But I don't see the manufacturers moving away from including that in their technology. And as you said in the question, it can be a very viable option for connecting to other devices.
Great, thank you, Megan. Yeah, so maybe next question is for Charles again. And we have from a recipient as well, I have 2 N7s, so Cochlear Corporation's device, and no residual hearing. Trying to get back into playing music, pitch perception is a challenge. I have been reaching out to musicians online for tips, any mapping strategies / rehab tips. It seems most CI musicians use a map with all processing turned off, and that's the best option I've found so far.
Thank you for the question. This is not a simple answer. I would say the following: a lot of the processing options that exist really are meant for speech, and it's often the case that if you turn off the processing, it will, in a way, interfere less with the signal and allow you to hear more of what you're trying to hear. But I think the way I would view this, and this is, I've often thought about how I would approach it if I had an implant myself, is that I would actually find an audiologist that is willing to take the time that's needed to really do some fine-tune mapping changes and do it with a musical keyboard in place, because you may find both weak spots and also strong spots, meaning parts of the frequency spectrum that are relatively in tune for you, and other ones that are relatively out of tune. And then you can hone in on the ones that are out of tune to try to potentially change the channel frequencies to make them more in line. Sometimes a very simple change in a frequency of pushing the limit up or down will make a particular pitch transition point better. And so it does take some time. It takes some, and you in a way have to be a little willing to experiment with your own hearing. And then you also have to be willing to be systematic about it. You can't just go to the symphony and wonder why it doesn't sound right. You have to, I think, break it down into the elements. And so starting out with pitch perception, I think, is the best way to do it. Also acknowledge that on the right, if you have two implants, I think that's what you said, those two devices are not synchronized to one another, either anatomically or electrically. And that's a big obstacle in trying to get two pitches in two separate ears to sound the same. So you might be better off working with one ear at a time when you're trying to fine tune the particular pitch map of that ear.
Those are great points, Charles. Yeah.
Can I throw one thing?
Yeah, sure.
I do have several patients who are musically inclined or just simply very sophisticated listeners. And for those patients that are able to, I can actually turn the programming software around so that my patients are looking at the same screen as I'm looking at. And I can show them what are the frequency boundaries of the sound that we're trying to adjust. And sometimes just kind of including them a little bit more in the process has helped, because we've been able to, as Charles said, make certain pitches sound a little bit more clear, or as my patients describe, a little bit less blurry. And so if they are able to do that, and I have the time to do that, that is something that's helped. So to Charles's point, if you can find an audiologist who you're comfortable with and who you can communicate with and has the time for that, there are certainly programming adjustments that can be made to try to optimize it.
Great. Maybe going away from the music, there's some more music questions, so we'll hopefully get back to them. I just wanted to keep it a little more, more diverse, I guess. One question that I thought was an interesting one, and we see that in clinic frequently actually, is one that pertains to reimplantation. And the question was, in the long term, do you think that most cochlear implant users will need to be reimplanted? Charles?
Yeah, it's a great question. I think that the answer is probably no. Now, I view it the following way. The technology is designed to last forever internally, meaning it's undergoes testing and design features that are not meant to expire inside your body. Now, the other thing is that we have seen people with old technology, 25-year-old technology that are performing great. And there's no guarantee that if you were to replace them with an quote upgraded internal processor, that they might hear better with a newer implant. And sometimes just keeping up with the external processors, which are generally backwards compatible, is sufficient. Now, that being said, it's always a possibility. I mean, there's things that can happen. Devices can break, they can malfunction, they can get traumatized. And so it is possible that somebody might need to be reimplanted. Thankfully, reimplantation today is a relatively quick thing. I mean, this is typically a long procedure where you basically remove the device. It typically has a very mature scar sheath at that point, and you can put the new device right back into the same scar sheath and hopefully get somebody up and running back again very, very quickly. And so while unfortunately we can't guarantee that nobody will need a reimplantation, I don't think it's a given at all for everybody. Right.
Yeah, technology upgrades certainly mostly pertain to the externally worn pieces. Megan, any thoughts on your end from the audiologist perspective?
No, I agree completely. The research shows that unless there's a device malfunction or some kind of issue with the internal, device from trauma or something of that, some kind of a failure, there's really no evidence that a new cochlear implant will perform better or as good as what they currently have. So that's not something that we typically recommend. Most of our patients can upgrade the external technology and take advantage of a lot of the improvements in that way. Our long-term implanted recipients, we have recipients with devices that were implanted in the 1980s that are still in place and functioning, and they're performing very well.
All right, maybe one last question. We have a little bit over a minute left. One question was, can the non-MRI compatible battery, I assume that person meant the non-MRI compatible magnet, right? In an older implant, be replaced with an MRI compatible magnet instead of battery without replacing the entire implant? To my knowledge, no. Charles?
Not right now.
Yes. So that's a pretty clear answer. So we have less than a minute. I would like to remind everyone that there is the exhibit hall. The virtual exhibit hall is open during the break. Please return at 2:45 and pick between the adult session and the parent session, so family-centered session that we offer, again, both at 2:45. And I think Donna wanted to introduce Teresa.
Right. Thank you, Oliver. That was great. And two superlative presentations by our presenters today, and great questions from the audience. Thank you very much. When we come back, we're going to be in two different rooms, and I will be in a room with Lindsay Zumbach on the adult side. Teresa Caraway will be in a room for parents. So I wanted to go ahead and introduce her now. Dr. Teresa Caraway is a speech language pathologist and auditory verbal therapist, and she's the CEO of a very special group called Hearing First, which is an educational endeavor of the Overcotter Foundation. And Hearing First supports families and professionals on listening and spoken language, and they provide awareness, education, and community. She has been recognized by her peers and by the families that she serves as a superlative professional with her thoughtful approaches and outstanding clinical skills. I've been privileged to work with Teresa for many years, and she's really a special person in the community at large. So you all will enjoy her inputs on reading to your child, and she's dealing with children of all ages. So if you have older children, you're going to get some great advice from her as well. So all for now, we'll see you back at 2:45. Thanks so much for being part of the first part of the event.